Hello and welcome to this webinar. We're so glad you've joined us today. We are glad to have you here for this webinar, Time to Invest in Primary Care Research, Findings from an Independent Congressionally Mandated Study. You can send all of your questions for our panelists to the Q&A icon at the bottom of the Zoom window for this session. And we have set aside a good amount of time at the end of the session for questions for our panelists. During the rest of the webinar, you can use the chat box to share questions, to share resources, and have conversation with the rest of the webinar attendees. Now I'll turn it over to Dr. Tricia Elliott, who is the president of STFM.
All right. Thank you so much, Emily. Appreciate that. Good afternoon, everyone. I'm Dr. Tricia Elliott. I'm the president of the Society of Teachers of Family Medicine. And I also serve as the Senior Vice President overseeing the medical staff, academic affairs, and also research affairs at the John Peter Smith Health Network in Fort Worth, Texas. Welcome to our briefing on the importance of primary care research and the need to invest in it at the Agency for Healthcare Research and Quality, also known as AHRQ. Our purpose today is to bring to your attention the results of a congressionally mandated study of primary care and health services research. We want to define primary care research for you, and we want to advocate for more and targeted funding of $5 million for AHRQ's Center for Primary Care Research. Primary care research, it can be difficult to understand, and part of primary care research can be considered health services research, but a great deal of it is actually unique. AHRQ funds the majority of federal primary care research and has a congressionally authorized Center for Primary Care Research, which unfortunately remains unfunded. Our speakers today will take 5 to 7 minutes each to further expand on this and other issues, such as some history of primary care research funding, gaps in research, examples of primary care research, relationship to COVID, access, and also address things around health equity and more. Now it's my pleasure to go ahead and introduce our speakers, and I'm going to begin in order of their presentations. First, we'll have Dr. Jack Westfall. He's the president of the North American Primary Care Research Group, also known as NAPCRG, and incoming chair of the Council of Academic Family Medicine. He practiced rural family medicine and conducted patient-centered practice-based research in Colorado for 15 years. He's now based in Washington, D.C., where he is director of the Robert Graham Center, which exists to improve individual and population health by enhancing the delivery of primary care. Next, we'll have Peter Mendel. He's a senior sociologist at RAND, specializing in health systems improvement and organizational change. He has served as principal investigator or major task lead on several national evaluations on primary care, including leading a recent congressionally mandated study sponsored by AHRQ to assess federally funded health services and primary care research, which we are discussing today. Dr. Mendel is here reporting on his work as principal investigator of the study and not for advocacy purposes. Then we'll have Dr. Jean Kutner. She's the president of the Society of General Internal Medicine and a past president of the American Academy of Hospice and Palliative Care Medicine. She's also Associate Dean for Clinical Affairs at the University of Colorado School of Medicine and is co-chair of the NIH-funded Palliative Care Research Cooperative Group, PCRC. Her research focuses on improving symptoms and quality of life for people with serious advanced illnesses and their family caregivers. And then we'll have Dr. Andrew Bazemore. He serves as the Senior Vice President of Research and Policy for the American Board of Family Medicine, ABFM. And as Senior Vice President for Research and Policy, Dr. Bazemore is responsible for managing all ABFM research functions and staff, development and implementation of an enterprise-wide strategy for research, co-directing the new ABFM Center for Professionalism and Value in Healthcare in Washington, D.C., where he works at developing national and international collaborative research partnerships. And then we'll have Ms. Ann Greiner. She serves as President and Chief Executive Officer of the Primary Care Collaborative, PCC, where she is focused on defining and implementing an advocacy, research, and education agenda that furthers comprehensive, team-based, and patient-centered primary care. Ms. Greiner is a well-recognized leader in the quality field. So this time, we'll start with Dr. Jack Westfall. Thank you, Dr. Westfall.
Next slide. So it's very exciting to be here, Jack Westfall. I'm a family doctor and get to work with lots of primary care researchers all over the country. So I'm going to give a little basis for sort of what's primary care research and why this study. I don't want to step on the next presenters specifically describing the study, but really there have been some concerns that primary care research has been vastly underfunded for the past 2 decades, maybe longer than that, but certainly for the past 2 decades. There's also been concerns that primary care research may just be part of what NIH and AHRQ are already doing. But there's a question about who's facilitating, managing, and guiding any federal investments in primary care research. Is there any process to it? Is there overlap? The 2018 administration budget recommended moving several of AHRQ activities to the NIH. But it was also concerned that maybe we didn't know enough about primary care research and health services research to do that yet. So Congress felt it was important for AHRQ to study it. Next slide. Well, this is about primary care. So this is the car white box. I hope you understand that every month, 1,000 people living in the community, about 800 of them will report symptoms, have an illness or injury. 327 of them will seek medical care, mostly in a primary care office. 10 or so, 8 are hospitalized, and less than 1 is hospitalized in an academic medical center. However, the vast majority of research is done in that lower right-hand corner of hospitalized patients in academic medical centers rather than out in the larger boxes of primary care. Next slide. However, as this slide shows, 46% of all outpatient visits are to primary care, 410 million primary care visits, and about 50%, 53% in this slide of people in the population of the United States will see a primary care provider each year. Next slide. So here's a little example of that car white box relating to respiratory illness, or in the days of COVID, what we might call COVID-like illness. Each year, or in 2017, respiratory infections were seen, 19 million patients were seen by primary care, and only a few 100,000 were hospitalized. Even for patients with pneumonia, the vast majority, over 9 million patients, were cared for by primary care with pneumonia, and just about 1 million patients were hospitalized for pneumonia. And so you can see that primary care is the place where most of the people get most of the care most of the time. And while there's urgency in the hospital setting, the vast majority of respiratory illness, or in this case of COVID, COVID-like illness, is likely to be seen in primary care. Next slide. Here's a study, a primary care research study that that includes both an asthma toolkit that was at the practice level and a community organization called Community Air. And this project really was around how do you implement really good asthma care in primary care settings, but also how do you help patients and community members understand the symptoms that they're having may actually be related to asthma and that there may actually be treatment. This study took place in Eastern Colorado. It included almost 800 people who were participating in the study, not just as patients, but as participants in the research. Next slide. And it worked. As you can see in this slide, the black bar is Eastern Colorado, and the gray bar is the rest of Colorado, and asthma hospitalizations decreased. Increased use of the right medicines, increased use of spirometry, and increased use of action plans, we believe led to decreased hospitalizations in primary care settings in rural communities. Next slide. Here's another study around primary care medication-assisted treatment for our opioid use disorder epidemic in the United States. This was in rural primary care, and this was again a practice and community-based primary care research study, and it did show an increase in the number of patients who were receiving appropriate treatment and staying in treatment for 6 or more months. Next slide. We know that mental illness is a common occurrence and it's been exacerbated by COVID, but where do patients with mental illness go for care? For patients with depression or any mental illness, if they have only a mental illness, about 40% of them are taken care of in primary care. But if they have any other illnesses, chronic conditions, diabetes, high blood pressure, heart disease, the more chronic conditions, the more likely they are to receive all of their care in a primary care setting. So the concept of complexity is really important in primary care research. Next slide. Well, what did this study find? I'm not going to spend too much time here, but I think the most important finding is that primary care research is not the same as health service research. It's not just a subset. And that this last bullet, we need targeted funding for a hub to examine and coordinate the federal primary care research investment. Next slide. The basic science of primary care is one of the gaps. Understanding what happens, where it happens, undifferentiated patients, symptoms and signs. Primary care research is not just about an individual disease, but it's about the person with those conditions. Next slide. And next slide. Well, $5 million is a good place to start. Now's the time. We need that money to help fund our Center for Primary Care Research so we can start coordinating the need within the federal government to identify and support primary care research. Next slide. I am finished.
Thank you so much, Dr. Westfall. Next, we have Dr. Mendel.
Thank you, Trish. I'm very happy to be able to share findings on primary care research from our congressionally mandated health services and primary care research study. Next slide, please. As was mentioned in 2018, Congress authorized AHRQ to contract an independent for an independent assessment of federally funded health services research and primary care research, and RAND, where I work, was selected to conduct that study. The objectives of the study were to assess health services research and primary care research portfolios funded by federal agencies, identify potential areas of overlap among those different agencies, and research gaps in primary care research and HSR funded by the government. Lastly, we were tasked to propose strategies to improve outcomes, value, and the impact of federal HSR and PCR over the next 5 to 20 years. Next slide, please. We used 3 primary methods to address the study questions. First was an environmental scan and portfolio analysis, in which we put together a database of over 93,000 research projects funded by federal agencies. Second, we formed 2 technical expert panels, one for HSR, health services research, and one for PCR, primary care research. And lastly, we conducted 50 interviews with a variety of stakeholders to obtain wider range of perspectives. The scope of the study covered all operating divisions within the Department of Health and Human Services, as well as the Department of Veterans Affairs, Veterans Health Administration, and included research grants and contracts funded between federal fiscal years 2012 and 2018. Next slide, please. As Jack mentioned, although health services research and primary care research overlap, PCR is a distinct field, and we used a distinct definition to identify primary care research projects. Next slide, please. And our study definition of PCR incorporated several common accepted concepts of primary care. So we defined it as research for care provided by clinicians responsible for the large majority of personal health needs that Jack highlighted in his presentation, who coordinate and prioritize the healthcare needs of those patients within family and community contexts. We also specifically included addressing social determinants of health. And lastly, clinical research on common health conditions that are not typically addressed by specialty care. Next slide, please. So we found there were 8 federal agencies that funded PCR according to our study's definition. We were able to collect systematic data on the research projects for 6 of these agencies. If you could just click to show that. Yes, thank you. And then next slide. So NIH funded the largest number of PCR projects. If you could click to show the bars, thank you. 750 projects, or about 5 times that of the next 2 agencies, AHRQ and the VA, who funded about 150 PCR projects each between 2012 and 2018. Partly, this is a function that NIH's total research budget is magnitudes higher than any of the other agencies that were covered in this study. And also this will be seen also in the next slide. If you could change, please. So in looking at the number of PCR projects as a percent of the total funded projects, AHRQ and CMS come out as dedicating the largest portion of their portfolios to PCR. So even though NIH funds the largest number, it's a very small proportion of their overall research portfolio. So what types of research projects do agencies focus on within their portfolios? One of our main findings was that federal agencies, as you would expect, have distinct PCR and HSR research portfolios based on their congressional authorizations, missions, and operational needs. Next slide. So for example, the research portfolios of AHRQ and NIH both had the broadest scope within the agencies that conduct PCR, but have different research objectives. AHRQ's research objective is to improve healthcare systems and outcomes. It's the only agency with a mandate to generate HSR, and it's, as Jack mentioned, also authorized as the lead federal agency for primary care research, but it does not receive designated funding for that mission. NIH's research objective is to enhance health of the nation, lengthen life, and reduce illness and disability. Much of its research focuses on specific diseases, body systems, and populations. So for example, a typical NIH PCR research project might focus look at different effective interventions to screen for and treat diabetes within primary care settings, and even for primary care physicians to work with and teleconsult with specialists to manage their patients. In contrast, an AHRQ PCR study might do that, but also focus on the infrastructure and process and systems for primary care practices for managing all their chronic diseases. And AHRQ PCR funded study also will typically look at how to further disseminate and scale up that intervention across the US health system. If you could click, do one click there to see the bottom. And other agencies' PCR portfolios are more limited in scope based on their missions and operational needs. For example, CDC has a focus on prevention services, the VA on veterans health and the veterans healthcare system, and the CMS on quality and costs of care for beneficiaries within its Medicare and Medicaid programs. Next slide, please. One of our questions, study questions, was looking at overlap in research portfolios, and we found that overlap in agency PCR portfolios was less of a concern than prioritization and coordination. Can you click on the next slide, please? And this was due to the size of PCR portfolios viewed as being small compared to need, and a lack of dedicated funding for coordination of PCR. If you could, next slide, please. We identified 2 overarching research gaps in PCR. Next, can you click? These were core functions of primary care to holistically address patient needs, what Jack was talking about, and things that are typically not covered in more disease or condition-specific PCR projects, and also for primary care transformation and the role of primary care in the wider healthcare system to optimize primary care's fulfilling its core functions, especially in our evolving and rapidly changing healthcare system. So next slide, please. So we proposed 3 recommendations specific to federally funded PCR. First was to initiate a strategic planning process across federal agencies dedicated to prioritizing PCR research areas. Next bullet, please. Establish a review process to proactively identify areas of potential PC overlap across agencies in order to lessen the time for agencies to recognize areas to coordinate research. And lastly, to provide targeted funding for a hub for federal PCR to both fund the core PCR gaps and coordinate PCR across agencies. Next slide, please. We reviewed 3 options for Congress to create a funded hub for federal PCR. First was to provide targeted funding for PCR to AHRQ. This is the most expeditious options, and the reasoning for that is AHRQ already having the existing statutory authorization for this role, history of sponsoring key studies on primary care systems and innovation, and expertise in synthesizing and disseminating evidence and tools to improve primary care. Our second was to create an independent PCR operating division within HHS, and lastly, to create a PCR institute within NIH. And this last option we recommended against. I am happy to discuss the reasons for that during the Q&A. But that is the main recommendations of the study, and happy to discuss that further.
Thank you so much, Dr. Mendel. Appreciate that very much. Next, we'll have Dr. Jean Kutner. Dr. Kutner.
Yes, thank you. Thank you to all of you for joining us for this important topic. I'm here to represent the Society of General Internal Medicine. So next slide, please. And next slide, please. The goals of my time with you are to explain a little bit more that difference between primary care research and health services research that you heard from Dr. Mendel, and describe the need, and then give some more specific examples of some actual primary care research studies that have been conducted to give you more sort of concrete examples of what we're talking about. Go ahead. So if we think about the differences here, and this is to, like I said, add a little more depth to what you heard from Dr. Mendel. If you think about, and this is from the report, what health services research, it fulfills at least one of these 2 conditions, whether it addresses at least one of the 3 output domains, so the quality of care, the cost of care, utilization, or equity, and then one of these input domains, which is in the next bullet, or it addresses that organization of care. So how does the care organize? How is it financed? What are the social factors and personal preferences and behavior? So that's the definition of the health services research. If you look at primary care research itself, that's more research on the delivery of primary care itself. And that may use health services research methodologies, but it focuses on that delivery of care. Or it may actually focus on the common conditions we see in primary care, whether it's how we manage diabetes or hypertension or substance use disorder or well woman care. There's many things that we focus on in primary care, and primary care research then can study those actual clinical conditions that we see, as well as how that care is delivered. So primary care research addresses the primary care professional services or setting regardless of whether it meets this criteria for health services research. Next slide, please. So the distinction really is a specific focus on that clinical part of primary care, recognizing the central role, as you heard from Dr. Westfall, that primary care plays in leading to higher quality, safer, and more affordable care. So while health services research may address primary care topics, health services research also often focuses on topics like insurance benefit design or healthcare policy changes that may be relevant to primary care, but they're not specific to primary care itself. So really think of these as complementary components. Next slide, please. So why is this need for primary care research? Primary care research can inform how we are enhancing the quality, effectiveness, and value of clinical care, while also addressing such important issues as healthcare disparities, which I know we've heard a lot about, especially in this era of COVID, and questions around systemic racism, as well as the care of underserved populations. So the message is that we need more primary care research to examine these core functions of primary care and transform the role of primary care in the health system, as was briefly mentioned by Dr. Mendel, including the role of primary care in reducing disparities. So achieving those full potential of improvements in primary care processes and outcomes requires this research that is specifically focused on how clinical care is delivered in primary care settings. Next, please. So I will next give you a few examples, and this is just a tiny sliver of the types of things that we're talking about in primary care research. And these are all very recently published studies, and I've included in the slides the citations if you're interested in looking at them in detail. So next slide, please. So this is a study that was published this year in Journal of General Internal Medicine that was focusing on diabetes. And this was evaluating the effectiveness of a clinical pharmacist that was embedded within the primary care setting that focused on decreasing cardiovascular risk factors, specifically diabetes and blood pressure, among Black patients in a large healthcare system. They co-managed the complex patients along with the primary care physicians and showed there was improved diabetes control. So it showed how a team-based intervention could improve diabetes control. Next, please. And you heard about the issues of mental health. This was an innovative study looking at an innovative way to actually embed primary care in behavioral health settings for people that had both severe persistent mental illness as well as chronic medical diseases. This was in a highly underserved population, and it showed that embedding primary care within behavioral health settings did improve blood pressure and diabetes control. So again, this is a study of a way to deliver primary care. Next, please. And this was a study, full disclosure, that I'm an author on, that was, again, around an innovative way to deliver an aspect of primary care, in this case, advanced care planning, which was using the group visit model, which has been used to manage diabetes, weight control, and some other things in primary care, using that group visit model to enhance advanced care planning, so filling out advanced directives, et cetera. And it did show that this group visit model was an effective way to deliver this important part of care within the primary care setting. Next, please. And then I thought I'd end with a last slide, which is a more of a study of the impact of primary care itself. Next, please. And this was a study using the Medical Expenditure Panel survey that looked at outcomes of patients that did or did not receive primary care, and found that those who received primary care had more high-value care, a little bit more low-value care, but overall better care, better healthcare access and experience. So another example of primary care research, in this case studying the actual outcomes of primary care. Next slide, please. And I'll hand over to our next presenter.
Great. Thank you, Dr. Kutner. Appreciate that. We'll now go on to Dr. Bazemore.
Thank you, Trish. I just want to start by talking a little bit about a definition of primary care, which I think is sorely lacking if we understand what primary care research is. I'm Andrew Bazemore, as mentioned. I am the Senior Vice President for Research and Policy at the board, but I really come at this conversation, which I'm glad to be a part of, with a perspective drawn from years of frontline work, and particularly in settings like community health centers and international settings where I've seen primary care and its manifestations presented very differently. And there's one thing that I've appreciated was that the term primary care is thrown about as if it were consistently defined and well understood, and in fact, it really isn't the case. And when you start looking at the history, I speak as a history major, you go back to Great Britain in the 1920s, coming out of a terrible war, and a recognition by Sir Bertrand Dawson and the Council on Medical and Administrative Services that said, you know, we really need to separate the notion of primary care from the idea of what we're doing in our secondary health centers and teaching hospitals. And we need to understand what that function is better. And it only took them a quarter century and another tragic war to really see that that was the essence and should be the center of a health system. And that was a realization that much of Europe adopted over the subsequent decades. We didn't really have the same pathway in the United States. And so by the time 1966 and major social, societal, and healthcare reform and revolution came around, we were recognizing that we'd begun to pursue fragmentation, subspecialization, growth of our hospitals in ways that had some really unfortunate effects. So when Dr. Willard, the Dean of the Kentucky Medical Center, presented an idea in a council report on education for family practice that we needed a new focus on generalism, and really birthed my specialty, family medicine, he was presenting the idea that we'd lost our way in our understanding of primary care. A concomitant report from a Millis Commission put back the idea that we needed to have individual relationships with personal physicians, a notion that you had to have some manner of achieving contact and entry in the health system that was going to be coordinated by someone who really did most of what you needed, and an idea that was really being lost at the time. By the time you reach 1978, the nations of the world had come together in consensus and said at the Alma-Ata Summit and in a declaration of Alma-Ata that this was really the center of any effective health system, and began to talk about ideas that brought out the salutary effects of primary care. Ideas like being that first contact, offering coordination, offering, again, comprehensive services, or at least the vast majority that any patient or family or community might need, and really pointed out that we needed more accountability and understanding of what these look like in order to operationalize these essential attributes of primary care. Our own Institute of Medicine in 1996 followed up and revised the definition to add in the critical notion of patients and family at the center. Community and integrated service delivery is really the ideal path forward. And these are ideas that run counter to what you've been hearing about in this talk as the typical product of a very fragmented and siloed research enterprise here. And the IOM went further and said, primary care is actually the logical foundation not only of any effective healthcare system, but should be the foundation here in the United States. But if we look at the reality of 2020 and the years since, is primary care is not growing and expanding as the center of our healthcare system. As a matter of fact, when we've looked at total investment, about 5 to 7% of the healthcare dollar is going towards primary care. That's right, it's about a nickel on the dollar. And COVID has only highlighted all the more what our sibling in public health is receiving and the absence of coordination between the two, much less research that can really tell us how we can build optimal paths to coordinating primary care, public health, community needs to detect and to trace and to mitigate the spread of a terrible pandemic. And that's just the really the tip of the iceberg. And that's only likely to get worse, as you'll see in a recent article, that the average frontline primary care clinician is going to lose as much as $70,000 in gross revenue per full-time physician this year. I tie all this understanding of primary care back to research to say it's no surprise that there's a direct correlation between the inattention to primary care, the absence of understanding of what it is and what it can do, and the absence of a specific funding space for the unique research you've been hearing about from the rest of our speakers today. I'll go ahead and go to slides now and say, I think I'm hopefully capturing the other speakers' notions in saying that primary care research has really been neglected and functionally homeless for quite some time. I'm going to say the word click a lot, so apologies, Emily. Can we go ahead and click and walk through the agencies? If you look at AHRQ, there is a congressional mandate to provide a home for primary care research, but no specific funding for that primary care research function. Next slide. You've heard us say that the NIH, the largest biomedical funding enterprise in the world of public funding, could be that home. It has even been presented as a possible home, but again, it's been created and designed to have very important but disease-based and organ-based institutes and centers. It's uniquely positioned to drive research, but it continues to struggle to get science into practice. And as I mentioned, the largest platform of frontline delivery in American healthcare, primary care. You can even look, next click, at newer agencies, the public-private model, the Patient-Centered Outcomes Research Institute, next click. Well, I was a part of a couple of studies looking at its first 6 rounds of funding and its second 6 rounds of funding. And the 2 Georgetown investigators actually went so far as to read every single grant abstract and to contact the principal investigators to try to understand if you're operating a brand new patient-centered outcomes research institute and the patient is receiving over half of their care from this primary care platform, wouldn't you anticipate that the settings and the ideas emerging from this new Affordable Care Act era institute might relate more to primary care? And in fact, we found little attention to core primary care research issues and studies from the new institute. And when our 2 lead investigators at Georgetown reviewed all the grants, they said, you know, if we just look at settings, we can only find about 18% of studies involving primary care settings. And you have to remember that we have a long history of being involved and having our patients recruited without actually being the center of the study or the research question addressed. Next slide. When we went to look, given the notion that, that Peter mentioned that NIH could be the home, retrospectively using their e-reporter tool back in 2006, at the proportion of grants that were coming from the NIH into one generalist discipline, family medicine, we could find nearly 50,000 grants and a little over $20 billion in funding, making up a pretty large pie if you look at it. But when we looked at family medicine, the piece of the pie that was served up to the largest of the generalist disciplines amounted to 154 grants and $45 million total dollars. You can see that piece of pie you're doing better than I am on a Friday afternoon, but I'll magnify it and repeat. That's about 0.3%, 0.3% of the grants and 0.2% of the dollars coming into this generalist discipline. Next slide. You could say, well, that's 2006. E-Reporter and the ACA have advanced us in some directions and put new focus on primary care. So we repeated the studies, this time with Rochester investigators. And I was not a part of the most recent effort in 2019, but using the same secondary data, we were able to say, you know what, we learned even more. The piece of the pie is about the same. We're also learning that what little funding is going into this generalist space seems to be highly concentrated. In the world of family medicine, it goes disproportionately to about 3 to 5 institutions, which account for the vast majority of the grant funding, and frankly, wear hats that don't look much like primary care. It's often family medicine and community medicine departments. You can go to the next slide. Tried to get to the source of this in our 2006 studies and started looking at the committees and the voice that a generalist discipline like family medicine might have at a large place like the NIH. And of nearly 5,500 members of 300 committees, the seat at the table, at least for family medicine, was very small. A presence on about 19 committees with about 21 total members. And again, to hit home, you can go ahead and click what that looks like. That was about presence on 6.5% of the committees and about 0.5% of all members. Next slide. We went and interviewed the directors of NIH institutes because this is a group that we very much like to see more primary care penetration into and learned, again, to the positive. Whoops, we can go back a little bit. That's okay. On the positive, there was a definite feeling that there was opportunity here. The institute directors, and you can go back a couple of slides, were showing us that, that they had and one more slide back, they had a perception that there was something really unique. The ability to understand complex systems, not single disease and organs, multimorbidity, appreciate that psychosocial dimension, the family context, a truly collaborative space that could be worked in by primary care, team approach, and real bridges between, again, patients, populations, and communities.
Dr. Bazemore, sorry to interrupt. I know we're going to have to go to your summary slide and move on to the
Summary
next
slide
slide.
it is.
Definitely get those
I'll
points.
summarize very quickly then. You can go to the very last slide.
Thank you.
We have a unique enterprise, as you've heard. It's also neglected and very much homeless. And in summary, your only congressionally mandated home for primary care research is in the Agency for Healthcare Research and Quality. It's even smaller center for evidence and practice improvement. And within that, this National Center for Excellence in Primary Care Research, which does have an existence, but no dedicated budget line. So you've got your largest platform for healthcare delivery, getting about 5 cents on the healthcare dollars. And as we can tell, really no dedicated singular line for funding for its research enterprise. I think it's probably time to at least give that national center some additional support. Thanks.
Fantastic. Thank you, Dr. Bazemore. Really appreciate that. Next, we'll have Ms. Greiner. Ms. Greiner, the floor is yours. Thank you.
Thank you. Thank you, Dr. Elliott. And it's wonderful to be here today. Next slide, please. So I'm Ann Greiner, and I lead the Primary Care Collaborative, and we bring together very diverse stakeholders across the entire healthcare system, clinician organizations, purchasers, and health plans, consumer organizations, and the list goes on. But what they share in common is this dedication to primary care as the foundation of a high-performing health system. This is our vision for primary care. Over 350 organizations have signed on to it. Next slide, please. My talk today is going to focus on one aspect of primary care research that actually Andrew Bazemore referred to, which is what does the US spend on primary care? And we got a history lesson from Andrew, and that was really helpful to understand the historic basis for how we do not view primary care as the center of the delivery system, although our European counterparts do. We spend 5 to 7 cents on the dollar, and the OECD averages 14%, with up to almost 20% of spend. And you need to ask yourself if that reflects our priorities as a health system to keep people healthy, return them to health when they get sick, manage their chronic conditions, and really have a holistic approach to health. I think it doesn't. 5 cents on the dollar. Next slide, please. And what are the implications of this underinvestment in primary care? We need research to really understand them in much more depth than we have. In the US, our life expectancy is below all the other OECD countries, and we spend twice what they do on healthcare. I've put PC spend where I had it for these countries, and you can see again, we are dwarfed by where the other countries spend. Is part of the reason why our life expectancy is so low, because we underinvest in primary care. I think it is. And if you think that line is plateauing, that's up to 2017. In the last 3 years, in 2 of those years, we've seen life expectancy go down. And I think we'll see that again in 2020. So we are not on a good upward trajectory. After 50 years of seeing life expectancy rise, we're really flattening out in the US. Next slide, please. We also see a lot of variability in primary care spending across the US. This is from a report that we issued last year, and the variation you can see in the different colors of green. We are issuing another report that will look at all 50 states, and the Commonwealth Fund just also came out with a report. You see so much variability, and we need research to understand. So what does that mean to the outcomes, patient outcomes, quality, cost, health inequities in each of those geographic locations? Decision makers need this information to try to understand if they are prioritizing the spending in their geographic area to achieve the kind of outcomes they wish to achieve. Next slide, please. And this has real world implications. We saw the big dot measure of health expectancy, but if you drill down, you also see that how much we spend has implications for whether or not we're going to have high rates of hospitalization, lots of emergency room visits, ambulatory sensitive conditions. Well, we have a lot of hospitalizations for those. What this slide shows is that a state like Minnesota that's invested a lot in primary care actually has far fewer ambulatory sensitive hospitalizations. It's also true when we looked at this for ED visits, higher spend, less ED visits, higher spend, less hospitalizations. And policymakers are very interested in this data because they want to be putting expenditures to improve the health of the population and keep costs in check. And that's putting those expenditures upstream, so we're not having to spend a lot on downstream expensive services like going to the hospital and being admitted and getting a whole suite of expensive services. Next slide, please. So this whole notion of primary care spend is getting a lot of attention at the state level and also nationally. States are starting to look at what they're spending across all payers and try to understand if it reflects their priorities. 13 states have introduced or passed legislation, and we had a banner year last year with 6 such states passing legislation. And they're using this information to inform their decisions about where to channel more dollars. And they are able to do this because they've passed legislation that requires the health plans that they regulate to put more money towards primary care. And they are looking to achieve such things as behavioral health integration, which can address patients in a more holistic manner, their medical needs, but also their behavioral health needs. Or to, for example, fund a community health worker to help connect patients to the community to get community services. We need a whole lot more research to understand what we can get from these sorts of expenditures and what kind of payment models, delivery models will really get us more value for the vast amount of money we spend in our country on healthcare. Next slide, please. I think that this has become only more important as we consider the impact of the pandemic on patients. We know that it has exacerbated health inequities, but also we're seeing many more issues related to mental health, decline in vaccines and in getting basic chronic care management. And this will all, I think, downstream have serious effects on patients. And we're also seeing tremendous vulnerability with respect to primary care practices in terms of their finances. A recent Green Center study showed that 48% of practices were reporting that their volumes were still way underwater. And that they were concerned that their pandemic financial support was running out. So here we are at a time when we are still in the midst of this pandemic, and we have a primary care platform that is quite fragile and also shrinking. Next slide, please. So I hope that I've convinced you that it's important that we have this kind of research for policymakers as they're trying to make decisions about expenditures and how to get the most value for their healthcare dollar. And I would very much urge those who have the ability to channel funds towards AHRQ to do so, because both public and private policymakers need the sort of research that can help them make the best possible decisions about their expenditures to really improve the health of our population and help us lift up that curve and get us back on a trajectory where we're enhancing life expectancy and not dealing with the reverse. Thank you so much.
Thank you, Ms. Greiner. Appreciate that. And thank you to the panelists for being here. So now we'll go ahead and move into our question and answer session. And we're going to go ahead and start with Dr. Westfall. Dr. Westfall, we do have a question for you. You mentioned some gaps in research that might have helped address issues surrounding COVID, actually, response and recovery. What are some of the other gaps in primary care research you would like to see funded? And do you think a new funded Center for Primary Care Research could really help erase these gaps?
So thank you for the question. I think the whether it's new funding for a new center or funding for the current authorized center, I think is crucial. I think the current center has a place. It's been authorized. So that may be the quickest and easiest way, as Dr. Mendel said, to fund that center at AHRQ. Some gaps that exist specifically related to COVID are some of those related to telehealth and what can be delivered by telehealth, and how do patients access primary care when physical presence may not be allowed. And right now there is a sort of a gap in our understanding of what's good telehealth. Is it telephone? Is it text? Is it video? How do you do it so that it's paid? How do you make sure that what you're delivering is high quality? How do you make sure that we don't try to deliver by telehealth things that require in-person care? How do you maintain the relationship on which primary care is based using telehealth? How do we make sure that patients can access telehealth via their usual source of care rather than simply some 1-800 number with a provider at the other end of a phone that doesn't have a relationship with that patient? So telehealth is a big one. I think the other is this link that Andrew talked about, Dr. Bazemore talked about, between primary care and public health. And I think right now what we're seeing is both of those organizations have been underfunded. And what we're seeing in COVID is the lack of resources in primary care and public health have left Americans without a way to link those important messages, like wearing masks, like getting the rest of your chronic care, even in the midst of a pandemic. And so I think some specific research around how does primary care actually attach to some of the other areas of care that are available would be important. There's certainly lots of just gaps that are clinical, multimorbidity. How do you deal with behavioral health and other chronic conditions? But I think the concept of delivery of primary care in the days of COVID is really crucial to understand.
Great. Thank you, Dr. Westfall. Dr. Mendel, we have a question for you. Why was the conclusion of the RAND study to recommend against a primary care institute within NIH?
That's a very good question. And it boils down to, as I mentioned, the mission of NIH is not well suited, and you wouldn't expect it to address some of the research gaps we were talking about in primary care, which are more systems-based, more holistic-based, how to take care of the patient as a whole. Some of the stakeholders that were in our technical expert panels and our stakeholder interviews also thought that creating a PCR institute within NIH would help stabilize some of the funding and also enhance the status of PCR within the research field. But we recommended against that. The cons to that, the disadvantages are the influence of the NIH research culture fueled by its mission to focus on specific diseases and conditions. Also, there are challenges of smaller institutes within NIH to coordinate PCR primary care research with the other institutes. In fact, we had several stakeholders within NIH saying that it's actually sometimes easier to coordinate research with NIH institutes and centers when you're outside of the agency. And lastly is the potential risk that other NIH institutes who do fund some of the disease and population-specific primary care research might reduce their funding for PCR if they know that there's a PCR institute, which overall would end up with less PCR funding, in the whole federal portfolio, which is something that would not alleviate the major gaps in research that we've identified.
Great. Thank you, Dr. Mendel. Appreciate that answer. Dr. Kutner, what are some of the more pressing research questions you have regarding primary care professionals, actually team care and practice organization to improve outcomes? Are there barriers to effective primary care team performance that you're interested in exploring?
Yes, thank you for the question. And I think it actually builds on what Dr. Westfall was saying, is the study of the most effective way to provide primary care in a way that's patient-centered and person-centered, while recognizing the different members of the team and how they can work at the top of their license, and not necessarily rely on what we all grew up with, which is that face-to-face visit, where it's the doctor doing everything. And we've across the country done a lot of transformation in primary care in terms of how we deliver that care. And then we need to study what's the most effective for what patient populations and what diseases. So it's really those models of care, so that everybody's working at top of license and we're using our resources in the correct way, and then never forgetting that it actually has to meet the needs of the patient, meet them where they are, no matter what their background, sociodemographic status, etc.
Great. Thank you, Dr. Kutner. Dr. Bazemore, where does primary care research fit within addressing healthcare disparities? And do you have some examples where we could engage in that and how we play a role? And do you think such a funded center in primary care research could help further research on health disparities?
I think it not only could, I think it is the logical place to park a wide portfolio of work in addressing disparities and in pursuing greater equity. When you look at its focus on translation, its ability to understand how you better organize healthcare and across systems to meet patient and community needs, to evaluate the innovations not as standalone innovations themselves, but how they actually work to provide real care in practice, and also how you engage in a time when we're facing a complete dissolution of trust, how you engage patients and communities and practices to improve their health, using principles like continuity and understanding what it means to both measure it, capture it, benchmark it, and act on it. I think it absolutely makes sense. And if you look at a lot of the COVID collateral that Dr. Westfall mentioned, where we've seen a 40% rise in mortality over expected in the first part of this year, it comes from these disparities first and foremost. We've identified that it is Black and Brown communities, it is places like rural that have the least access to care generally, where you're seeing so much of the newer and COVID-related disparities arise. And I think primary care is in the perfect position with the largest, most distributed frontline network for conducting research to address this.
Great. Thank you, Dr. Bazemore. We've got only a couple minutes left, and I'm hoping that Dr. Westfall can do this in about 30 seconds because I've got one more question after this. Dr. Westfall, do you think the huge NIH RADx UP program, that's the Rapid Acceleration Diagnostics Program for Underserved Populations in NIH, do you think it'll be any different from past NIH track records in primary care research?
Well, the short answer is no. The long answer is yes, if we elbow our way in. And I think part of this will require those of us on this call, those of you who are listening to this, to step up, stand up, raise your hand. It may mean put your hand with your palm out. It may mean elbowing somebody. Primary care should be part of RADx UP. There is no way we're going to get through COVID response and recovery without primary care. Let me just reiterate that. COVID-19 response and recovery requires primary care, and it requires primary care research to understand how best to deliver that.
Thank you, Dr. Westfall. Great message there. Ms. Greiner, I'm just going to give you the last question before I wrap it up, just in a minute or so. You discussed the need for increasing the primary care spend, mainly in terms of funding for clinical care. What are your views on how this relates to the need for primary care research?
Well, I think what we really do want to understand is, what can we spend with respect to primary care delivery that will get us to the kind of health outcomes that we all want to achieve. And that's really where the research comes in. So, I am not of the opinion that just putting more money into primary care is necessarily going to get us to this nirvana. We really need to understand into what kind of delivery models, into what kind of payment models, and that's where the research really can happen. And I really want to echo what Jack said about primary care is pandemic preparedness, and we need the research. We need to understand, you know, how to make sure that primary care is there and available to help patients as they think about all the vaccines, the flu, the COVID vaccine. And, you know, it is really critical that we have a robust primary care infrastructure now more than ever.
Absolutely. Well, thank you to our incredible panelists. And I just want to say, now is the time to begin, everyone. We know we can't fund all that needs to be done, but let's get started. This additional $5 million will provide a dedicated funding line for AHRQ Center for Primary Care Research. And now we can begin that coordination that's needed within the federal government to identify, and let's go ahead, support primary care research. We thank you for your time today. We are here for you with any questions afterwards. Please reach out to us. Thank you so much.